Good evening, everybody. It's really, really nice to have you all here tonight on what's going to be, I'm sure, an absolutely fabulous webinar. We're very fortunate that we've got Dr. Jennifer Seddon with us, who is a senior lecturer at Oxford Brookes University. And tonight we're going to be looking at the patient experience of withdrawal from prescribed medications, a massively important area and one which I think is getting more and more attention. And this one is very much focused around practitioners. This is going to focus on Jennifer's recent research project aiming to improve and how we aim to improve patient experience. And following Jennifer's talk, we're going to have a little panel discussion. And for that, we've got Yankee Lakhar with us, who is a senior pharmacist with Turning Point, and Paul Hemsel, who works in providing support for primary care practitioners and their patients with prescription medication issues, and also has lived experience himself. And I will be adding my 2 penneth worth from a primary care perspective. Now, during the webinar, if you've got questions, please put them in the questions and answer box, okay? And then we'll filter those and we'll go through as many of those as we can with the panel. The chat's there. If you just want to make comments, feel free, but please don't put your questions in the chat, okay? So we're now going to look around exploring the prescription and management of medicines with a risk of dependence or withdrawal, and particularly focusing on patients' experiencing of their care. And just before we start that, we're going to run a little quick poll, just asking you about what your role is. Okay, and I'm sure the answer's coming up anytime soon. There we go. That's a nice, good. That's a great split. I really like that. Excellent. Okay, so with no further messing about, I shall hand over to Jenny, and thank you very much.
Thank you very much, Steve. I'm really pleased to be here tonight, and I'm pleased to see that so many other people are interested in this topic as well. So as Steve said, I'm a senior lecturer in psychology from Oxford Brookes University, and I've been the lead researcher on a research project that's aimed to improve patient experience of care for people who are prescribed certain prescription medications. And that study has been running for the last 2 years within primary care services in a particular area of the country. So I'm looking forward to talking you through that. But before I do, I have a little bit of a favour. So one of the things that we're hoping to do now that the project has ended is to write a policy brief to try and effect policy level change. So I'm really interested to hear your thoughts and your comments and your suggestions in terms of what you would like to see change at a policy level in terms of top-down processes that would best support you to best support your patients. You know, what would you like to see? It could be things like you want to have the reintroduction of individual patient lists, for example, or it might be that you want more detailed guidance on how to do a deprescription process. You know, whatever it may be, if you can pop a little suggestion in the chat, that would be fantastic. And if you can put the word policy in front of that, we'll know that that pertains to the policy context. So I'm very pleased to be here, and I'm very excited to talk to you about this project, and I'm going to try and keep to time. So I know I've got about 30 minutes to talk about the particular project. What I'm going to do is I'm going to give you a little bit of background to it and why we decided to focus on this topic. I'll talk to you about what we did, what we found, and then we'll talk about some reflections for practice. So some things that you could maybe take back to you and implement within your own clinical practice. So why did we decide on this particular project? Well, I'm going to hold my hands up at this point and say that this wasn't a topic that I identified or that the research team identified. We wanted to make sure from the outset that this was a topic that would directly address the needs of beneficiaries. And so to do that, what we actually did is we convened a group of people with lived experience of medication dependence, and we passed the bat over to them and we said, what would you like to see? You know, what do you think research needs to focus on going forward? And we ran a series of focus groups as part of that process. And at the end of it, we ended up with 8 potential topics. And then the research team went away and we did a literature review and we looked at each of those topics in depth, and we came back and we worked with the focus group participants again. And we said, this is what's been done in each of these 8 areas. This is the scope of future research. This is the potential impact. And then we asked people to rank those in order of preference. And the topic that came out on top was improving the experience of care. Now, we then took that step further and we presented at an AGM of a specialist prescription medication service, which I don't think exists anymore. But we went along to that AGM and we said, this is what we would like to do. These are the 8 topics that the group identified. What do you think of these topics? And then can you vote in order of preference? And again, the one that came out on top was improving the experience of care. And then as a further kind of belts and braces approach, we then did an additional consultation with another 10 people, both practitioners and service users, to make sure that this topic chimed with their own experiences and to make sure that they also felt that it was worthy of our efforts. So it was pretty clear from this process that this was a topic that was dear to most people's hearts and that they did really want to see research focused on this particular area. Now, fortunately for us as a research team, right about the same time, we also had Public Health England, who conducted their review of prescription medications. And they focused on opioids, benzodiazepines, Z-drugs, gabapentinoids, and antidepressants. And I'm sure many of you are familiar with this report. It's got a lot of attention over the last few years. But one of the things that this report highlighted was also patient experience. And it highlighted that patients aren't perhaps having the best experience of care as they possibly can do. And some of this centered around lack of information and barriers to treatment and support, and lack of medication reviews, lack of non-medical treatment options, and so on and so forth. So we had a pretty good idea that we were on the right track with this particular topic. So as part of the study, we used a methodology called experience-based co-design. And you may have come across this in your work. It was a methodology that was developed in the NHS by the NHS for use within the NHS in the noughties. And it's since started to be used in many healthcare services around the world. And the idea behind this methodology is that you kind of hand the reins over to patients and healthcare professionals. The idea is that they are the ones that know best. And that if you want to make changes, it needs to be designed for the people who are going to use that system and implement that system. So as part of this, you bring patients and healthcare professionals together to identify the areas that need improvement, and then to work together collaboratively to develop improvement initiatives to improve healthcare services. And in a perfect world, this would take about a year. But unfortunately for us, we decided to launch the study just as the COVID-19 pandemic started. And so it took a little bit longer because everything had to be moved online. So this is an overview of the different stages that occur with the experience-based co-design. So it's a qualitative study in nature. So the idea is you go out and you conduct in-depth interviews with both patients and healthcare professionals. And that's to better understand their own experiences. The interviews with patients are actually video recorded, and the interviews with healthcare professionals are audio recorded. And the reason for that is that at stage 2, you create what we call a trigger film. And it's a short 30-minute film that charts the patient journey. So it tells the patient perspective right from inception. So in this case, it will be from the point of prescription through to how that medication was managed, and then through to the process of deprescription. So you're left with a tool for change. It's a really powerful tool to trigger further dialogue and to help pinpoint improvement priorities. And we also analyse the data from staff interviews at stage 2 as well. And then at stages 3 and 4, we hold a series of feedback events. So we bring the patients and healthcare professionals who've taken part in those interviews back together. We feedback the results of those interviews. We talk through the findings. We have lots of discussion around those. And then we ask patients and healthcare professionals, they start working together, and it's actually participants who identify the priorities for service level improvement. So it's them that say, this is the areas that I think could benefit from change. And then at stage 5, you run a series of co-design groups. So we run 3 co-design groups, again with the same participant group. So patients and healthcare professionals came back together and they collaboratively designed improvement initiatives. They designed solutions to improve the experience of care and how they could be implemented within general practice. So who did we have that took part? So we had 5 GP practices. From those practices, we recruited 15 healthcare professionals and 20 patients. So it's not a large sample size, but for EBCD, it doesn't need to be a large sample size. The idea behind this is that you recruit a small, meaningful group of participants and you work with people over a longer period of time. So the idea is that, they're involved in all stages of the research, from the interviews right through the process of implementing some of those co-designed solutions.
So what do people say? So what do patients tell us? Well, one of the biggest things to come out of the
interviews is that patients simply didn't feel that they had enough information about the medication. In some cases, people felt really quite ill-informed with regards to the potential side effects, and some people didn't realise that the medication had a potential for dependence. And people wanted to know how long the medication would be prescribed for. They wanted to know potential side effects, potential dependence. They wanted to know how it would be managed, and they wanted to know how it would be deprescribed. Now, this was quite an interesting point because when we interviewed clinicians, they recognised the importance of information and actually felt that they were providing their patients with enough information, because they realised that this was a really important thing to do. So there was a little bit of a mismatch between what patients were telling us and what clinicians were telling us in the interviews with regards to the provision of information. And one of the potential explanations for that is that patients readily admitted that when they come to that prescribing appointment, they're often not in a point to be able to take on board detailed information. Patients saying, when I go to that first appointment, I'm in crisis. I'm a mess and I just need something to help me through. And so perhaps I was given that information and I just didn't take it on board. So information was a big theme in terms of what the patients told us. Patients also had concerns with regards to whether the medication was right for them. They wanted to have access to alternatives. They weren't sure whether, they did have some concerns with regards to potential side effects. And for some people, that did affect how they used their medication. So not everybody used it in accordance to how it was prescribed. Some people would purposely take less than they were told to take. And some people would skip doses because they were so concerned about potential side effects and dependence that it changed how they used the medication. The other big thing to come through was medication reviews. And this also relates to this information point as well. So patients wanted to have medication reviews. They saw them as being really important and a good point of contact with the clinician to discuss whether the medication was working, to discuss whether any changes needed to be made, and as a point of contact to have more information about, the plan going forward. But a lot of participants in our study said that they simply hadn't had a medication review, and where they had a medication review, it wasn't as personalised and as individualised as it perhaps could be. And what they wanted to see was medication reviews being prioritised with more of an in-depth discussion and a more kind of collaborative approach in terms of planning the next steps and having discussions as to whether that medication could in fact be reduced with a view to deprescribing. Working in partnership was also another big point, and this comes back to continuity of care. People wanted to have an established relationship with their clinician. It was something that they really, really valued. They wanted to have this established relationship with somebody that they trusted and that knew their medical history, and that they didn't have to reiterate their story at every appointment. So working in partnership was a really big point for patients. And then lastly, as I'm sure it will come as no surprise, the one that came up was that stopping medication was a really difficult process. And many patients in the study really struggled with the process of deprescription. People experienced some side effects and didn't always know where to go to in terms of support. And in the absence of any kind of formal structured support, most people would turn to the internet for informal advice. And some people actually titrated their doses on the basis of information that they were able to pull off the internet. So for patients, this was a really quite inherently difficult process. So what did healthcare professionals say? So there's a lot of synergy between what patients said and what healthcare professionals said. First and foremost, they said, actually, we are concerned about this medication, but there's no other option available to us. We do have concerns. We know that this isn't always the perfect solution. And if I could, I would refer people to mental health services or pain management services or sleep hygiene services. but they simply don't exist, or they have long waiting lists, or there's limited provision in my area. So in the absence of this other help, the only option available left to me is to issue a prescription. And the concerns were especially apparent for gabapentinoids, benzodiazepines, and opiates. And people say, once I've issued that prescription, it's also what comes next. If I've issued it, what will I do afterwards? If this isn't going to be a long-term solution, what do I do next? Medication reviews were also seen as very, very important. They were seen as the ideal opportunity to touch base with a patient, to talk through how the medication was working and whether anything needed to be changed, and was seen to be the perfect opportunity to start to instigate a deprescription, to suggest that to patients and have a bit of a dialogue going as to whether that was appropriate. However, clinicians, GPs are very busy people, and medication reviews aren't always practical. They just simply aren't possible in the context of heavy workloads and lots of patients to see and complex case histories. And for people who had chronic healthcare problems, who were prescribed multiple different medications, medication reviews took on another level of complexity. So although they were seen to be very, very important, it wasn't always practical to carry those out on a regular basis. And then lastly, clinicians said, actually, deprescription, it just feels risky. We clinicians recognise that the deprescription process takes time. It's a long, gradual process. It requires a lot of support. People, quite often need regular support from the clinician who's leading it. And GPs in particular said, we don't have the scope to be able to do that. We just don't have it within our working time frame to be able to do it. And also clinicians said, actually, when a patient is relatively stable, instigating a deprescription can feel quite risky, because what if something goes wrong? What if there's an adverse outcome? Am I clinically liable in that case? So in many cases, clinicians say, I don't feel entirely comfortable doing this. This isn't my bread and butter. One person comes to mind who said, I'm in the business of prescription. This is the business of prescription. We haven't quite got to grips with how we do deprescription routinely on a regular basis just yet. So there was a little bit of issue in terms of, I'd like more support around this to be able to be confident in how I lead deprescription in the process in the future. So that was a bit of a whistle-stop tour in terms of the results of the study. So that was fed back to all the participants in the feedback sessions. And then we asked people, if you remember, to come together and to identify the priorities for service level improvement. And this is what people came up with. And I'm aware that this is quite a lot of text on the screen, but I've purposely left this as it is because it preserves the participant voice. So there were 12 different priorities that were listed all in all, but you'll see that there's significant overlap between some of these. So, for example, priorities 1 to 4 all centre around this idea of improved information and improved communication. So we had 3 co-design sessions in which to design solutions for these priorities. Now, we obviously didn't have the time to design solutions for all 12 areas, so we asked patients and healthcare professionals to rank them in order of priority. And the ones that came out on top were improved information and communication, continuity of care, and alternatives to medication and alternative ways of managing symptoms. So what I'm going to do now is I'm going to show you some of the co-designed solutions that were identified as part of the project. So for improved information and communication, we had a couple of suggestions, and some of the practices have already started to implement some of these to improve patient experience. And you'll notice that none of these are rocket science. These are quite simple, easy to implement changes. So first and foremost, it was providing easy to read, accessible information. And many patients said, the patient information leaflet that comes in the box, it's too long and it's too complex and it's written in tiny little type and it's just not that accessible. So it might be that you signpost people to lay-friendly websites, like patient.co.uk, for example. And one of the things that has been implemented as a result of the study is that patients who took part, the GP services that took part now send accurate messages as standard to patients when they're first prescribed this medication. And that provides people with written, accessible information and links to further sources of support that they can refer back to as well. Another suggestion was to conduct a mini review shortly after prescription, and then again, that's just seen as a short appointment just to touch base and say how are you getting on, and to reiterate some of that initial information in terms of expected duration of prescription and how it will be managed and how it will be deprescribed, and potential side effects and potential for dependence. And that doesn't need to be done in person, that could be done over the phone, but it's just to make sure that, it's another avenue to provide information to patients. Regular medication reviews, so making sure that they happen and they're prioritised for this particular patient group, and that they're personalised and tailored to that individual. And making sure that people are seen in person for that first prescribing appointment. And that was felt by both patients and healthcare professionals to be quite important. Another suggestion was to hold group consultations whereby, a small group of say 12 to 15 patients would be invited to the GP surgery to have an educational session with a clinician on that medication, and it would be a chance to ask questions and to have lots of information provided. So in terms of continuity of care, in an ideal world, we'd have continuity of care for all patients. And ideally, we would like to make sure that patients prescribed these medications had continuity of care across their patient pathway as well. That might not always be possible. Being realistic, that might not be possible. So if we were going to cherry pick the aspects of the patient journey in which this is most important, patients said it was during deprescription that they needed to see that same clinician, and that was really important, and also for medication reviews. So if it can't be if it can't be ensured across the whole of the patient pathway for that particular patient group, then they were the 2 time points that people really wanted to see focus on. Now, to ensure continuity of care during that deprescription process, it was also suggested that perhaps clinical pharmacists can lead that process, because they have a little bit more flexibility, they have a little bit more time within their appointment schedule, and they can safeguard some of their time a bit easier than GPs can. And they obviously have the necessary expertise in order to lead deprescription regimes as well. And then another suggestion that was posited was to have a teams-based approach. So that's where you have a small team of, say, 2 to 3 clinicians from a given practice who work in collaboration with one another. So it could be GPs and pharmacists who decide that they will work collaboratively, and that patients will see any one of those members and they will still have that continuity of care experience. And this is something that's gaining traction in the literature as well. It's not been widely implemented as of yet, but it's a possibility that shows potential promise.
And then lastly was alternatives to medication.
And this one was a really tricky one to design solutions for, because ultimately what people wanted was access to alternatives to medication, and that simply isn't the case at the moment. So what we did try and focus on for these was to make sure that things could be implemented at a local level, and then perhaps at a policy level, we'll start to call attention to the lack of alternatives to medication. So patients said that even though access, alternatives to medication may not be freely available, they wanted information on that. So they wanted to have that same knowledge that the clinician had. So for them, it would have made a difference to say, okay, well, in an ideal world, I would refer you to a sleep hygiene clinic, but I can't do that at the moment because of X, Y, and Z. So what I'm going to do in the interim period is I'm going to give you this medication, and this is going to be the plan going forward. And so that they were clear on all possible treatment options that could be available, even if they weren't available in that immediate time frame, in that immediate moment. And it was also just to make sure that local level services were being utilised wherever possible, including mental health link workers and social prescribing schemes and other similar alternatives. And then something that I'm sure that many of you already do anyway is to have routine discussion of self-care treatment options. So again, it comes back to that information point, just to make sure that patients are fully informed.
So what changes have happened
since we've wrapped up the study? So in the 5 GP practices that we worked with, More information is provided at the point of prescription as standard now. So there is signposting to lay-friendly websites. All patients are sent an automated text message with additional information at the point of prescription. Practices have prioritised offering extended appointments for patients who are undergoing a deprescription, and continuity of care is prioritised during that deprescription process as well. One of the GP practices actually created a specialised deprescription clinic, and that was jointly led with a GP and a clinical pharmacist. And they've used a really proactive approach to both identify and to engage patients. So anyone who's been on a medication for a given length of time is automatically sent a letter to invite them to come in and discuss their medication with a view to deprescribing that, and that's been quite successful. And then other services, other GP services are considering implementing group consultations as a way to provide more information to patients on medications. So, reflections for practice, kind of what is the take-home message? So there's a few things that I think we can think about in terms of would make a difference to patients straight away. First and foremost, it would be providing additional information. And as I said, in this particular study, clinicians actually felt that they were doing a really good job at providing information, and they recognised the importance of that. But from a patient perspective, they didn't quite feel that they were getting enough. So there's always more that can be done. So consider the points at which you can provide additional information. Can you similarly set up an accurate message as a routine for anyone who's prescribed these medications? Can you conduct a mini review shortly after prescription? Can you make sure that medication reviews for this patient group are prioritised? So it's just thinking through what you could do to support that process. More regular support and follow-up. So yeah, people wanted more regular support and follow-up. So what could you do in that sort of field? Again, it could be things like having a mini review after that prescription appointment, making sure that medication reviews are regular and that they are individually tailored with a lot more probing questions in terms of, is this medication still needed? Can we look to deprescribe? Do we need to make any changes with regards to the dose? Can we put a plan in place for deprescription? Continuity of care. Now, I recognise that this isn't always possible. And sometimes there can be systems that prevent patients from booking with the same clinician, and that's comes down to a resource issue more often than not. Is there any way that can be changed so patients can book with a clinician of their choice? Can you implement the use of micro teams to try and provide more continuity of care? Can you utilise clinical pharmacists, especially at certain points of the patient pathway during deprescription, for example? And then coming on to deprescription, it's about considering who's best placed to lead that deprescription process, and it may not necessarily be a GP. Can you involve a clinical pharmacist for that, who can better support or has better capacity to support patients on an ongoing regular basis, to walk them through, kind of do a bit of hand-holding through that deprescription process? Can you offer extended appointments during that time? Can you make sure that there's continuity of care during that time? And then alternative treatments, it's more about kind of considering and discussing, so making sure that patients are fully informed with regards to all treatment options, even if they're not available in that immediate moment. So hopefully that's given you a little bit of a flavour and some food for thought for your own clinical practice going forward. What I've done now is I've just popped on some further resources if you want to go and do some bedtime reading. Some of them I'm sure you've already read already. So you've got the Public Health England review there, and then you've also got some relatively recently issued reports both from NICE and from NHS England. And then I'll just finish up to say that if anyone has any questions at any point whatsoever, I will be thrilled to hear from you. So please do drop me an email, or you can catch me on Twitter, or X as it's now known. So yes, any comments or suggestions or anything you want to discuss in the future, I would love to hear from you. And I will stop sharing now, and then I'll pass back over to Steve.
Thank you, Jenny. Thank you for taking us through that. And it's interesting. It's nice to see some really collaborative research going on, and some fascinating results, and definitely something, a lot of food for thought there, and certainly a lot of activity in the chat So we'll come to that in a minute. Now, I'd just like to remind everybody that, of course, we as addiction professionals are providing this webinar for you all tonight, and you can join addiction professionals, and you can even join for free and get access to quite a lot of the content that we already have. And the team will be putting the details of how you can do that into the chat whilst we're getting the panel together. So we're going to go to the panel now. We will do our best to answer any of the questions that you may have. So you've already met Jenny. I'm Steve Brinksman. I'm the clinical director with Addiction Professionals, and I was a GP in Birmingham for 31 years. And I'm also the medical director with Cranston. I've also got with us Yankee Lakar, who is a pharmacist and clinical services manager working with Turning Point, and is also on the board of Addiction Professionals. We've got Paul Hemsill with his user experience and his experience of working in primary care, supporting patients with prescription medication problems, and obviously Jenny as well. So if you've got any extra questions, put them in the chat, and I'll start with one here. And I think probably this go to Jenny in the first instance and then maybe Paul, but what about peer group support? Would this be a useful resource following deprescription and possibly even during it as well?
Yeah, so peer support was something that came out actually in the context of the study. So some patients said that they would have found it really useful to have access to peer support services, but there was a real hesitancy from the point of view of clinicians in terms of they didn't know any peer support services first and foremost, and there was a bit of reluctance to signpost people to kind of internet peer support services in case that information wasn't factually correct. Or so I think there's a bit of a mismatch there. I don't think that we're quite there in terms of the level of provision that there needs to be. And obviously that can't work in a vacuum. So it needs to be clinically led, really, first and foremost. But yeah, definitely peer support services was something that patients said that they would have wanted and would have really appreciated. It's just a shame that there isn't more of that around.
Would you like to add anything on that, Paul? Or
yeah, so I'm a smart recovery facilitator. I did the training early on in recovery because I know I wanted to. There was lots of other people out there like me that couldn't get the support that should be there that wasn't. So I'm a smart recovery facilitator, so I hold regular weekly groups on that, both face-to-face and online. And in the new role that I've just started in Derby, we're putting in pain groups, which is peer-led, and it's run by, I attend quite a few that we're opening them up all around Derby now. For people that can't access them, we're putting in place, trying to get them in through social prescribers and health and wellbeing coaches through Derby County Community Trust as well. So some of them are piloted by GP surgeries, certain surgeries. I went to one and did a talk at Moorway Sports Centre last week at one of their pain groups, and I'm getting a few referrals in that way as well, just talking at pain groups. So there's a lot of that happening at the moment as well, and there are a lot of social prescribers, coming into that as well now. But I think it is very important, yeah, peer support, definitely.
okay. And another question here is, I suppose it's probably me and you, Paul, but someone saying there's a GP in the area who's actually cutting people off benzodiazepines, particularly been on the long term, quite quickly, if not immediately. And how are they going to, what's the best way to manage that? And certainly from my point of view, and I'm sure Yankee might have a view on this as well. Obviously, if you're going to start a medication, you should probably know how to stop it. But that plan needs to be in at the beginning of how you identify whether it's the medication is being successful, whether it's providing benefit that outweighs any potential long-term risk, and if it isn't, what the process for that should be. But certainly, and this is other comments come through here as well, withdrawal phenomena following long-term benzodiazepine usage can last many years, occasionally, certainly many months, and it is important that it's managed more carefully. And I noticed there's a lot in the chat about a lot of GPs not feeling comfortable how to do that. So any suggestions how we help support those people, those GPs?
Is that me, Steve?
You and Yankee, I think, and then Jennifer, maybe she'd want to come in as well.
I think it does vary a lot. I've found it with what I've been doing where you will get that. And I try and go and do a presentation at the clinical meetings just to remind them of the importance of nice guidelines are there, but they're just guidance and never follow them. It has to be a person-centered approach when you're doing a reduction of any medication. It doesn't, I always say it's a marathon, not a sprint. It doesn't matter how long it takes. So it's got to be person-centered. And that way, you know, I always work a plan out with the patient. The patient's happy with that. They feel in some form of control of that then. So they're not being rushed. They don't, if they do suffer any withdrawal, it's minimal. If they do, we can slow it down or stop it for a bit and then carry on. We just work it around the patient. And I am finding that it's getting there because I've been doing some work with Joined Up Care Derbyshire as well on lady prescribing and writing policies. I noticed a lot in the comments earlier about a standardized reduction plan. There isn't a standard. It's got to be a person-centered thing, which is why I say, you know, I don't follow the NICE guidelines. So that's what I can add on that from my point of view anyway. If that's helpful or not.
Yankee?
I definitely agree and echo what you said, Steve, and Paul as well. What I'd like to add is I think the importance of, like how you said, when clients get started on these medications, I think the importance of having those conversations as to what they should expect from that treatment. What are the signs of developing a dependency? And if that was to happen, how can they get in touch with us as prescribers? Because I think a lot of times we might see clients who might have an accident during pain clinics, and we might start prescribing, but I think also educating them on what the side effects are, what the dependency looks like if you start developing, engage with them. And if the tolerance has been built, there has to be a collaborative plan, like how Paul said, in what are the goals which client has or patient has in terms of coming off that prescription? What does that look like? And actually agree a plan which aligns with the timelines they have in mind. And that's quite important because of the various psychosocial factors that come into play with clients who battle this. And I think that's why that's quite important when we talk about deprescribing. And very much agree with like what Paul said, that there is no structured treatment plan. We have to actually work with the patient, their goals, their timelines, and see what works for them. Sometimes it's okay to actually stop in the middle and say, the reduction needs to be halted for another 2 weeks, 4 weeks. We'll revisit it, have a patient-centered plan, introduce them to peer mentors, provide that external support they require, and then restart. And I think that's what gets us successful detoxes, albeit getting patients off these medications successfully. Otherwise, all we're doing is deprescribing someone, destabilizing them, and then starting that journey all over again. So that's what I'd like to add. And I think if we work collaboratively, be it GPs, pharmacists, peer mentors, I think the recovery outcomes and the patient experience can be phenomenal.
Anything you'd like to add to that, Jennifer?
I think they're really good
It's
points.
from both Paul and Yankee, actually, that, you know, it does need to be personalised, it does need to be individually tailored. I think it was a shame that in the NICE guidance that was issued last year, very much talked about the importance of deprescribing, but didn't really reiterate that message. And I think what people have been left with is, well, how do I do this? And people are looking for these kind of very structured deprescription regimes. And actually what the message that we need to get out there is there isn't any kind of standardized regime. It's going to be very individual for each and every person. But from a clinician's perspective, they're left wondering, well, how do I get this started, and how much do I take it down by, and how long should this go on for, and what's normal and what's right and what's acceptable. And it's about getting that message across that there isn't any designated length of time. It's just a slow, gradual process that needs to be tailored to that individual person. And that's kind of what's missing from the messages coming through from a guidance perspective so far.
Yes, I do think, I mean, my own view is generally not starting in the first place is the easier option, if you can do so. But there is, often people feel that they've nothing else to offer. And as you say, I liked your comment about discussing what would be the best treatment, even if it's not available. And just to sort of show that the risks and the giving the information from the medication might be much greater. But then when people are prescribed, I think that, using sort of arbitrary short-term 4, 6, 8 week reductions probably isn't going to be very successful. And we did have a comment about people, patients often then starting to doctor shop within the practice to find somebody who they think may be more amenable. And one of the points I would often try and raise is it's really, really important to try and discuss this as a practice and have a consistency of approach. And I think this is where using the micro team and consistent people may well be a beneficial going forward. Paul.
Yeah, I just wanted to add, Steve, just to reiterate that, when I was facing this battle, I was scared. I was embarrassed. I felt guilty. I was ashamed. But if someone had mentioned the word deprescribing to me, I would have been so scared. And a lot of patients face that. They face a lot of fears and barriers about opening up to actually having a problem. So I try and get that across to GPs in one of the presentations that I do, but also a lot of GPs as well will have patients that are in denial, like I was initially. Everyone else found out that I got a problem before myself because I wouldn't admit it to myself. But how I engage with patients that may be in denial is I put a presentation together for these patients that explains everything that happened to me, both physically and mentally, when I was reduced too quickly. And then it plants that seed, if you like. So if they're not ready now, if there's something that can be put together to show the patients that this can happen long term if you carry on doing this. And it's quite surprising when the patients that have been in denial, when I first met them, they've said, well, that's happening to me, but I didn't realize it was caused by the medication. And I've just let them go away and have a think about it. And then they've rang me and saying, can I come and see you? So it's about planting that seed as well. And, some patients have been on this stuff for years. And they do use it because they feel they can't manage without it, not just physically, but mentally as well, because it becomes a crutch. So it's how we manage that, it's how we work with that patient.
Absolutely. And yes, and I think this also one of the things that came across to me from your research, Jennifer, was the medication reviews and how vital they are, but how often skipped they are and hurried and become oh, you're still taking so and so, is it okay? Tick, thank you, move on to the next drug because there's 10 on the list, which in itself should probably flag up a need to do a really thorough medication review. And I do think that perhaps what you're saying, Paul, about in terms of even if no changes are made at the medication review, it is an opportunity to discuss the risks, to discuss the benefit and plant that seed, as you say. Any thoughts on medication reviews, Janky?
Definitely agree, Steve. With regards to, I think, medication reviews, I've worked in addiction for some time, and I'm sure you'd probably agree that sometimes I think we're all party to like just going through the form, doing the tick box exercises, and I think the quality is compromised. But what I can say is within the recent organization I have worked with, that's something that has been acknowledged, the existence of co-occurring needs which clients have, which requires more attention, has been also addressed with the recent reports like Carol Dane Black report. Now, what that highlights is the importance of having ongoing conversations about what recovery looks like for that patient at that point in time. If during the medical review just because they are stable, that doesn't actually get us the outcomes we want to achieve for that client. And I think the importance of reiterating the fact that if everything is stable, when the client started the journey and they were using heroin on top, and now that they're stable, it's about having those ongoing conversations about, be it reduction. If they are not ready on that day, like Paul said, it's okay to actually keep on having those conversations in a timely fashion. That doesn't have to be every day, every week, but even if that can be timed once in every 4 weeks, to say, where are you at in your recovery journey and how can we support you? Because I think medication is a small part of it, but until all the other pieces are in place, be it their accommodation, social factors, mental health, we cannot actually address it. And that's where I think addiction is such a complicated arena, where we need to look at all of that and have those conversations to be able to have a patient-centered recovery plan. And I think that's where we can actually then talk about what deprescribing looks like for that client. It might be reduction, it might be coming off it. And I think that's what we need to actually work on within addiction during prescriber reviews. So I quite like what Jenny's talked about, is the length of prescriber reviews, the time it's allocated should be longer, so we can have those meaningful interactions. And I think another important point is having that jointed approach with the recovery workers being present in that clinical review. And what that allows us to actually, they can build that relationship with that client and have a joint care plan which they can go away and action. Because just as clinicians, we see them, depending on where you work, I think 4 times a year or twice a year. But those recovery workers are the ones who are actually going to see, be peer mentors, who will see those clients most days and support them. So I think that's the important bit, and that needs to be reflected on in medication reviews.
I think, unfortunately, that's, apart from the few enlightened areas where, like Derby, actually support workers and people helping, clinicians around these medications that are, potentially dependency forming, are few and far between, unfortunately. And substance misuse services definitely have the upper hand there. There is one question, and I'm going to go to it because I agree with it, and it's something I used to do, but it's about where patients are looking to do a reduction and then will wind themselves up and get almost withdrawal type phenomena before it actually happens, simply because they know it's coming. What I used to do, and the person putting the question has suggested as well, is actually get the patients to do their own dose. So I used to give people, say with diazepam, we're doing a 2 milligram reduction, and I'd get them, when they felt comfortable, to pick a couple of days in the week that they felt they could do that reduction themselves, and then talk to me afterwards. And I know it doesn't work for everybody, but I do think sometimes empowering people that they're in charge of the process rather than a recipient of it can help. I don't know if anybody would any of you want to disagree with me on that, but no. Okay. Now, Jenny, there's a question here saying thank you for this, and has this been published?
We're working on that.
Working on, okay.
So we're actually working on a suite of different outputs. So there will be some papers that come from the project. There will also be a policy brief. We're doing a research animation that will be sent. So the ICB that hosted the study has agreed to send this out to all the GP practices in that particular area. And the research animation will be shown on the TV screens in GP practice waiting rooms, to give patients information about their medication in terms of what they can expect and what they can do to ensure that they receive the best possible care. So we have a plethora of outputs in the pipeline, but as of yet, I haven't got anything new and exciting to show you, I'm afraid. Okay. But I can always get back in touch with addiction professionals once those reports have been published, and perhaps you can disseminate those to
I'm sure we'd be delighted. We have had a couple of people saying, could they sneakily ask for a copy of the PowerPoint? But I know the webinar will be available, but I suggest if people want anything, they contact you directly from your contact details. Is that?
Yeah, that'd be fine. Yeah.
All right. And now there's also another question here around, should all practitioners or prescribers who are prescribing opioids particularly outside of end of life of care also be prescribing naloxone or ensuring issue of naloxone. And I reading an article today in I think in the Guardian, looking at the fourth wave of synthetic opioids in the United States, and the numbers of, I think it was over 100,000 deaths last year from synthetic opioids in the States. Sounds a good idea to me. Any views?
200 a day every day in America. Yeah, I carry naloxone when I go out and see patients, Steve, because I'm on the DAG, the Drug and Alcohol Advisory Group for Derby and Derbyshire now. I blag my way in to get training for it, so I just carry it with me. I think it's vital, you know, it's important. Looking at nasal naloxone, I think we just had the funding for nasal now, because it's seen as less invasive. But yeah, I think it's, yeah, definitely, I think it's vital.
Yangi?
I think I definitely agree, and it's just the power of naloxone. I'm quite passionate about it. Before we start prescribing, I think naloxone comes first for me, and I think we're in a good position now. We've got lots of options, including injectables and naloxone. But alongside that, empowering hospitals and ED departments or acute hospitals with nasal naloxone, which we have available. Historically, there's always been apprehension around storing or dispensing naloxone at the point of admission, and only some hospitals may offer the option of dispensing naloxone where substance misuse is identified, be it at discharge. But as we're all aware, sometimes the acute presentation comes with the idea of sometimes that clients may self-discharge, and that actually raises their community risk of overdosing massively. And I think that's where there's a lot of work that can be done, and education within hospitals where we can introduce nasal naloxones even before we start stabilizing patients on be it methadone or buprenorphine. And I think that both of them go hand in hand, and the importance of increasing alongside inpatient, increasing it in community. So be it pharmacies, be it the criminal justice teams, the councils, the hostels. I think a lot of those areas now we can reach out and actually increase the distribution of naloxone in the community, which just reduces the overdose risk, especially with lots of opioids, as Steve said, circulating in the community.
Yeah. I also think it sends potentially a very powerful message to people you're initiating a prescription for, to say, actually, the risks of this are sufficient, it could kill you or somebody else, and therefore, you know, you or a carer or someone else needs to know how to use this, and you might be able to use it and save someone else's life. So it's a win-win. But I do think we often, perhaps because the medication is slowly titrated up, we sometimes don't think about it when we're starting off with, you know, cocodamol 3500s or whatever, and then by the time you've got up to a fentanyl patch, you've probably missed the boat in terms of asking. Not that you should be using fentanyl patches, they're really not good. Okay, but that does come across to another question. There is really, I mean, when we've got people we are trying to support through a deprescription process, and then they are admitted to hospital or go into emergency departments, is that a potential blip, a potential bump in the road for these people with their journeys? Do we find that there are issues from acute hospital admissions?
So I've got a quick point to add on this
note. One of the things that came out of the interviews with clinicians in the study was sometimes a little bit of frustration with some of the prescription practices from secondary care services or from patients who've come from other practices that they subsequently inherit, where sometimes the combination of different prescriptions may not make sense, or the dose may not make sense, and then they're left kind of trying to deal with that and work out what's the best way to progress from that. So I think if someone was undergoing a deprescription regime and they found themselves back in hospital, then yes, that's obviously going to have an effect on someone's progress, but it doesn't need to be the end of the story, so to speak. We've talked about it being very personalised and being very individualised, and that's just something to take into consideration, and perhaps we need to restart it and look at if any more medications have been issued during the hospital stay. Then it might be that we start a few steps back and then just start working with that patient on a collaborative basis again going forward.
Okay. And another question in here is around commissioning. I know obviously a number of practices try and improve the quality of their prescribing and have support from pharmacists around that, but not necessarily directly commissioned. And there always seems to be this large divide between substance use services, which are commissioned to local authorities, and then GP prescribing and ICBs or ICSs. Never the twain shall meet sometimes. And I don't know, your service I think is interesting, Paul, because that was what was the background to the commissioning of that service in Derby?
I did a pilot for Derbyshire under public health for substance misuse. But then when the pilot ended, they said they weren't going to fund it because they didn't believe it was a public health problem. And I was gobsmacked. What? They said, let me rephrase it. What we mean is it's a primary care problem, so it should be funded by primary care. So as the day the pilot ended, because it was all voluntary, I had a phone call from someone saying, we've heard about what you're doing. Can you come in and talk to us? And I started this back in employment for the first time in 9 years on April the 3rd this year. So I was doing the pilot for about 18 months, and then now I'm doing it full time for primary healthcare Derby. So, and it was, everyone interested in every GP surgery I went to, part of the pilot said this is a gap that's needed filling for such a long time, because I don't know I do know what it's like. It's a postcode lottery, but nowhere in Derby or Derbyshire, no drug services are commissioned. You just get 4 psychosocial intervention appointments sent back to your GP. Your GP doesn't know what to do with you if you were hard at it like I was. So yeah, it's a postcode lottery and it needs commissioning because there's no OST in Derbyshire or Derby. I know there's many other parts of the country that are like that, but some do help, thankfully.
Right. And just to you on that, Jennifer, do you did you find that there were issues around commissioning of services and funding for services that came across through the research that you were doing?
So that didn't actually come across all that much in the context of the research, but obviously, it's been in the media that the very limited service provision that we currently do have, many of those services have lost their funding over the last few years. So when we first started to map the landscape with this back in kind of 2018, 2019, there were a very small handful of services across England that were providing support, usually through charities, to people who've been prescribed these medications who'd found themselves dependent. Now, slowly and steadily, all of those services have subsequently lost their funding. I think there's one left over in Bristol, and that's pretty much the last one. And there was headlines last week to say that, the antidepressant helpline that had been operating from a service in Bristol has just lost its funding, and that's been pulled. And that helpline was meant to be for the locality. It was meant to be for the Bristol area. But in fact, what actually happened is that they ended up fielding calls from across the country due to a lack of other service provision. And I think overall, there is one NHS commissioned service that looks at prescription medication dependence and supports people who've experienced prescription medication dependence, and that's in North Wales. And that's the only one, as far as I'm aware, that we've got in the entire country. And that is just appalling, because this is a topic that needs to be addressed. And there is clear interest in this topic, and there's increasing recognition that this is an issue and that something needs to be done, but that isn't matched by the picture on the ground, unfortunately.
Yeah, I agree. Unfortunately, it is something that there's a massive gap, and at the moment, I don't see how they're going to close that. Now, I'm just going to go back to Paul, and then we'll finish in the question and answer. I've been a slightly naughty chair, and I forgot to put our poll in earlier, so we've just got 2 little quick polls before we finish off, and then I'm going to let Paul have his space. So first is, do you intend to make any changes following what you've heard today? And then while you're voting, Paul, can you? Yeah,
sorry, Steve, I know you're going to tell me off for this because I know we're short on time. But just to, again, if people are reduced too quickly, they still need to function. I went looking for a heroin dealer when I was reduced too quickly. I've never touched anything illicit in my life. Thankfully, I didn't find one. But this happens. People buy fake pills online from unregulated pharmacies that are laced with not fentanyl that's causing the problem in America now, it's nitazines in England. People are dying. There's cases recently with isotretinoin, metanitazine, etonitazine, all different forms of it. And people are dying just by taking one fake pill, mostly because they are reduced too quickly. So it's vital that people are reduced as a person-centered approach, like I said. So, yeah, that's all I need to say. Just reducing too quickly never works. Thanks.
Absolutely. It's something to have a discussion. And when what you want and what the patient wants is the same thing, it's a lot easier than so that's the key. Get the person on board, and then when they're on board, do it kindly. That was what I would say, and make sure that you're discussing it all the time. Okay, so thank you for that one. And then we're just going to one final poll question. And while that's coming up, if you could pop that in, your answers in, that would be great. As I say, the webinar will be available on the Addiction Professionals website. You are more than welcome to go and have a look at it. The details of joining should be there. I just want to say a big thank you to our panelists, to Paul and to Yankee, and especially to Jennifer for presenting that fascinating piece of research. And I just hope this is something that we can, continue to close that gap, because this is a massive need. And with that, I thank you all for attending, and I wish you all a good night, and may see some of you for our next one in October. Thank you.